Health Alert is brought to you by OU Physicians in Tulsa. Hello, welcome to Health Alert. I'm Pam Butler. Today we're going to talk about palliative medicine, and joining me is Dr. Jennifer Clark with the University of Oklahoma School of Community Medicine. Welcome to the program, Dr. Clark.
Thank you.
Now, before we start talking about some specifics of palliative medicine, tell us what is palliative medicine or palliative care? Is that about the same?
Yeah, they're synonymous. Palliative medicine has actually just been recognized by the American Board of Medical Subspecialties as a subspecialty of 10 different medical boards. Those include palliative medicine, includes pediatrics, internal medicine, family practice, and those subspecialties that would lend itself to its practice.
Okay.
The practice of palliative medicine is interdisciplinary. As a physician, I'm part of a team of people, including social workers, chaplains, pharmacists, nurses, and therapists that provide care to patients who are living with a life-threatening illness. Okay. The specific issues that we pay attention to in caring for patients and their families are the advanced decision-making that has to happen within medical care, and helping them with the confines of their goals and values make those decisions that are most pertinent to them.
Okay.
Another big part of it is symptom management, and that includes those of physical symptom management as well as emotional, psychosocial, and spiritual or existential components to suffering.
Now, when you talk then about palliative care, does it have to be where the person's at the end of life stage in terms of only 3 months to live or 6 months or some type of a prognosis such as that, or can it just be anyone that's dealing with a chronic illness that may not be life-threatening at that point?
Yeah, so end-of-life care is one component of what we do. Oftentimes, end-of-life care is synonymous with hospice care and is a type of health care delivery system that can be elected by those who are very end-of-life within the last year to half year of life. Hospice care, end-of-life care is one part of palliative care. Palliative care stretches from the time of diagnosis on, and so depending on the need and kind of where the community that has incorporated palliative medicine into their practice, palliative care can be involved very early in the process or anywhere through the trajectory of illness.
Okay.
Where we are most effective is when diagnosis comes into play and we are a part of the restorative or curative measures that are being provided to a patient, and we work with their subspecialists and their primary care physicians to relieve the suffering and all those aspects that we talked about earlier that's associated with living with a complex illness.
Now, you mentioned some of the components. Let's talk a little bit about those.
Yeah.
One, you talked about sort of decision-making issues that people have to face. What are some of those decision-making sort of concepts that we need to be aware of? Is it who is going to speak for me if I'm unable to speak for myself, as far as do I want to be on life support if it gets to that? Do I not? I mean, what are some of the issues we need to realize are there?
I guess starting very late in the process, talking about when you're in a very advanced disease, and talking about the treatment options that you have and weighing the risks and benefits, and are they really providing you a benefit, and are the risks really worth it? Risks include, life-threatening risks, symptom risks, and things like that. Good example would be palliative chemotherapy. Is that providing me any benefit, or am I just having a lot of side effects just because I'm taking chemotherapy, and is it worth it? Obviously, those include resuscitation orders. Am I at a point where if I were to have an acute event, something where my heart were to stop or I were to stop breathing, would advanced resuscitation, including intubation and ventilators, CPR, and those type of things, gain me any benefit, or would it just prolong an inevitable dying process? And talking to families about really what that means. With our media today, there's a lot of misunderstanding about what resuscitation really is, and what benefits it provides people, and so we help families really understand what that means. So that's very end in the disease. in the beginning of disease, we really help families understand the impact of the decisions that they're making and help weigh, okay, is this surgery really worth it? Or is there another way to manage my symptoms? Is there another restorative measure? Working with all of their physicians and helping them basically process the information that they have been given and asking, kind of helping them fully understand in an informed way as much as you can about how to make those decisions, and is it really something that applies to their life in an effective way.
Now, do you help people, because sometimes within families when you're looking at those kinds of issues it becomes, if I can't speak for myself, or who would I need to support, what kind of consideration should I have there? I mean, should I look for someone who's really in my family, that's close to me? Should it be someone who's outside the family where they may be more objective? I mean, are those things that you kind of help people process through at that point as well?
Exactly. Advanced directives, and Oklahoma has a well-defined advanced directive that you can find actually on the State of Oklahoma website. And what the advanced directive does, it talks about terminal care and the effect that you can't speak for yourself. And a big part of the Oklahoma Advanced Directive names a healthcare proxy. This is different from a power of attorney. This is a healthcare proxy, and this is the person that you name that would be responsible for making decisions for you when you couldn't speak for yourself. What that document represents is a conversation that you have had with the person that you appoint, that you have sat down, spoken to them about your values, your goal system. You obviously can't you can't predict the future and don't know what the future holds, but you can have a good idea. If I am at this point, this is what I would wish for my treatment. And the person that you elect needs to be sensitive to your goals and value system. What is it that you really value in life, and what is acceptable to you as a quality of life? And so if that's a family member, whether it be your spouse or your sibling or a friend of yours, or someone that you trust that may be outside of your very close circle, oftentimes it's typically someone's spouse, child, or family member, but I've seen the gamut of folks.
Let me ask this question. What if a person says, and how do you sort of reinforce this, that, can I change my mind? I mean, if I select certain people or I tell you certain things, can I change my mind?
Yes. It's very important, though, that people understand as we get more and more ill, our ability to clearly think and have the capacity, which is a very clinical decision-making possibility. I mean, it's something that we assess. Do they have the capacity to make these decisions? Waxes and wanes and actually goes away pretty quickly at the terminal and stages of disease. And so it's very important that early on these conversations be had so that the issue of capacity does not come into play, if that makes sense. And so obviously these decisions are always fluid. Life changes on a day-to-day basis. Relationships change on a day-to-day basis. And obviously the option to change is always, at the behest of the patient. However, that's limited when our capacity to really have executive functioning and advanced decision making goes away with terminal phases of illness or sickness. That always that's kind of when the issue would become difficult to deal with.
Okay, and like you said, and in this for first consideration, those are all the kinds of things that you talk to persons about, especially with chronic illness or the end of life stages that are really critical beyond just the symptomology and the management and that type of thing. Okay, what we're going to do is we're going to take a break, and then when we come back, I want to start to focus some specifics, and I want to start with children when we look at this whole issue of palliative care in terms of what are the considerations, how do you treat symptomology, especially in a child who may not be able to even tell you exactly how they're feeling. Okay?
Sounds great.
Stay put.
Thanks.
And you stay put. We'll be right back.
Did you know that getting up and getting active for just 60 minutes a day is all it takes to help you get stronger, look better, and feel great?
Or that fresh fruits and veggies aren't just healthier and crunchier, they can taste better too?
Eating better and getting more active is easier than you think.
Yeah! Keep watching for some fun and easy ways to discover the magic of healthy living in your life.
America.
Let's get healthy together!
Well, welcome back. To continue our discussion on palliative care or palliative medicine, joining me again is Dr. Jennifer Clark with the University of Oklahoma School of Community Medicine. Let's jump in. I want to talk about children. This concept of palliative care in relation to children has got to be a difficult one. How do you begin to work with children?
It's been interesting. Pediatric palliative care has the same principles as what we would apply to young adults or even in the very geriatric population, but obviously kids are a special group of people. They have parents that are making decisions for them. These children have not lived a life where they can weigh in on their decision making and where we're headed, even though you would be surprised, even the youngest of kids can really help their parents or guardians make decisions for them. As palliative care physicians and practitioners, nurses and social workers and everyone that really looks at a family within the confines of their child being ill, we help them through the process. Pediatric palliative care happens prenatally for those children that are diagnosed with chromosomal abnormalities or fatal illnesses in utero, and we help them through the neonatal phases where the child may die shortly after birth, and help the families through that process, as that loss is extremely great. Obviously kids, as they get a little bit older and out of that newborn period where we lose many of our children. Actually, if you look at the pediatric population in the United States, over half of the children that die are under the age of 1 due to chromosomal abnormalities, congenital heart disease, and things like that. And so there are a lot of what we do in pediatric palliative care is done in that age group. Obviously, as we move out of the early years, we get into the more cancer diagnoses, neurodegenerative diagnoses, so kids with muscular dystrophy or any of the storage diseases that may happen. And those kids we palliate with symptoms. We help decisions as far as, is chemotherapy helping? What symptoms are they having associated with that? Kids are pretty resilient and can kind of fight a pretty good fight with regards to their symptoms, but they'll tell you straight out their activities drop, I hurt, and things like that. And they give you pretty good signs if they're not able to talk about, I don't feel so good, just by their affect, who they are, how much they play. And their parents are really their voice. Their siblings often are their voice. And so really looking at the family as a whole and using them as a unit to apply the ideas of decision making and symptom management to helping that family through the process of a child being very, very ill.
Now let me ask this question, because sometimes in the hospital, excuse me, we're accustomed to these little different smiley faces and frown faces and things like that. Are those things helpful with children as well? I remember being in the hospital and you've got to point, although you can say I'm hurting like all get out, but point to, on a scale of 1 to 10 with these little faces to give some idea of the level or intensity of pain. Is that helpful with children?
It very much is. Believe it or not, the FACES scale was developed by a nurse here at Hillcrest Medical Center in Tulsa. So we have an international accredited person that developed that here. The FACES scale is very helpful for children who are able to articulate or verbalize. So usually late preschool years is when we can use that scale. And it's one that they, oftentimes it's mistaken in that, the provider looks at the patient and what kind of face they're making, and that's not the case. It's actually asking the patient, how do you feel today? What picture best depicts how you feel today? And then based on that, we can kind of rate the symptom that they're talking about, whether it be pain, breathlessness, fatigue, and those type of things. And so those kids that are talking, usually 3 to 4-ish, is the earliest stages we can use that scale. Otherwise, we rely on physical exam and really seeing the child and how active they are, how much they're eating. And children that are pre-verbal, we really rely on the providers to tell us, whether it be parents, bedside nurses that really know the child, kind of how are they acting today? Are they themselves? Because they are the best identifiers of their personality and what's being affected.
So even with the faces with the young children, you actually use that to gauge how much pain medication they're going to get? I mean, is it sort of like a sliding scale based on those pictures? Because as caregivers, we're really concerned about especially kids with chronic conditions. We want them not to suffer, but we don't want them to be over-medicated, where whatever function they have, you're just zapping that as well. So do you use that scale to give you some idea of what percentage or amount of medication?
It does help. That scale is for more acute pain, so something that's a new process and not necessarily a chronic process.
Okay.
So if a child has underlying pain, whether it be from cancer pain or from spastic pain, from cerebral palsy or those type of illnesses, we treat that more based on activity and kind of their overall picture on a daily basis. Now, if they've come into the hospital for a surgery or they've had something acute, that's when we really use that FACES scale to help us dictate, okay, if we're not, if we're kind of closer to the 8 to 10 scale, we really want to ramp up their pain medication, because in children, if you control their pain, they're actually much more active. And so it's a titrating up very slowly and watching their activity and how they respond to the scale to help us with regards to medication. But yes, obviously the big concern is, over-medicating and allowing a child not to participate. And so this is happy balance between under-medicating where they're not participating, kind of finding that, right combination where they're able to have their pain controlled, participating in their daily life, or over-medicating where they're sedated.
Now, let me ask this, because when you look at palliative care with young children, I'm thinking about some programs like pet therapy. Do you incorporate that, and is it helpful? And even foundations such as Make-A-Wish and working with kids or people coming in for different things. How does that work in terms of the overall picture of what you do?
So symptom management, as I said, is not just physical. It also comes with spiritual and existential thinking as well as psychosocial. So kids really, their whole identity is surrounded by who I am in my family, who I am in my friends, trying to figure out that whole thing. And so social interactions are a key component to pediatric palliative care, even for symptom management for physical pain. Kids are amazing in that they have such plasticity with their brain. We can teach them self-hypnotic therapies, cognitive behavioral therapies that can really help manage not only their physical pain, but also their spiritual and existential pain, and managing why is this happening to me? And that in turn gives the child an empowering feeling of being able to do that. Things like pet therapy and child life are a key part of that, and empowering that family and that child to do something as simple as coloring a picture, as simple as art therapy, touch therapy, pet therapy, and all of those things are extremely important in pediatric palliative care. And honestly, that's one component that's now translating into adult palliative care, where we have a lot of art therapy for folks that are really struggling with the concept of illness and their identity. And so pediatrics has really championed that concept with regards to doing that.
Well, let me ask this question too, because in our last segment we will talk more about adults and geriatric population. If children go home, they're able to actually go home and continue. How do you reach into the home to provide some of these same kinds of support systems and services? Because a lot of times we're afraid that once we go home, it's going to be worse because nobody's going to be around. All of this stops.
Right. So palliative care is a spectrum of care, and obviously very early in the diagnosis we work with the subspecialist and the primary care physician hand in hand as a team. And so oftentimes either home health is usually in the house at this time. When they come into the hospital or even into the clinic, we add or subtract things based on the needs. And so it's a constant assessment of, okay, where are we within this? Can we help in a different way? Do we need to have more child life? Do we need to have a spiritual assessment? Do we need to do more symptom management? Are we headed into a decision about surgery or more chemotherapy? And so working with the subspecialist and the primary care physician to really find out kind of what the needs are. As a palliative care service, we're just starting in the Tulsa community. And so we're still finding our way to figure out kind of how we can insert ourselves into what practices are here in Tulsa. And so right now we're working with St. Francis Children's Hospital, obviously the pediatrics clinics within the community, and then specifically obviously at OU where we're located. And so we're finding our ways so that families can find us to help manage their child that is ill. And so that's kind of where that is in the early stages. Now, as we progress through disease...
Hold on. Yeah. We're going to have to take a really quick break, and then we're going to come back and we'll pick up on that thought and move into adults.
Sounds great.
All right. Please stay with us. We'll be right back.
40% of businesses never recover after experiencing a major disaster. Make a plan at ready.gov/business.
Welcome back. To complete our discussion talking about palliative medicine or palliative care, joining me again, Dr. Jennifer Clark with the University of Oklahoma School of Community Medicine. Now let's jump in. On our last segment, when we sort of had to rush off to a break, you were talking about as we move along the spectrum. Is that moving along the spectrum into hospice care? Continue that thought for me.
Yep. So early on, it was a joint effort with home health and the primary physicians, subspecialists. And as the child progresses through disease, and if the cure is not an option, and we progress to the terminal phases of illness, hospice then can be incorporated into this child's care. And as we spoke about previously, hospice is a type of medicine where nurses, social workers, chaplains, physicians, therapists come into the home ideally. Hospice can be delivered in different locations, but most of the time in the home, in helping a child through the last phases in death part of life, and what that means, the symptoms with it, and all of the processing of grief that go with that. Okay,
and I want to move into the adult phase, and in moving into the adult phase, I want to start with the hospice phenomena within adults, only because of a personal experience. And I'd like for you to tell me how common this is as far as what you may know. You may not know at all. But with hospice, I had an uncle who was moved into hospice not too terribly long ago. And when he went into the hospice facility, there were no medications other than for pain. Of course, the food was where he had to request, but he was unable to really request very much. So you really had to almost bring in other kind of supplements, like if you wanted liquid supplements or things such as that. And of course there was some turning that they would do to try to do that. How common is that with hospice? If you get into a facility, do they pretty much stop a lot of those other external things other than pain management because you are at the end of life?
It depends. Each facility is different. In Tulsa, we are very fortunate to have Clare House, which is our hospice institution here in town, where each one of the different hospices, and there's a lot of hospice companies here in Tulsa, bring their patients there for extensive symptom management. So there would be pain or breathlessness, agitation, and things like that. So each institution is different, but we're very fortunate to have Clare House in town. Kind of thinking about more the terminal phases of life and kind of how do we deal with that. It's been interesting, our culture, because we have kind of the diaspora where our families have moved to the winds essentially. In the olden days, and I'm talking just 20 to 30 years ago, we would bring our dying family members into our homes, and so death was a regular part of life, and we saw that process. As our families have spread across the country, we don't participate in that part of life very often, and so parents, families, spouses don't see what dying looks like on a regular basis. So we've had to teach families what's normal. And one of the big things is the concept of artificial nutrition and hydration. It's been in the news and media because of Terry Schiavo's case and others similar to her. As we begin to die, and we're in the last phases of life, and when I talk about that, I'm usually talking about within the last month, 2 weeks, days to life, our body actually is very smart. And that it starts shutting down, and we take food in, and thirst, and those sensations actually go away, and it's more for pleasure. So if people are alert enough to ask for those things that they love, it's more for a pleasure than for sustenance, because our body's unable actually to process liquids and food and things like that. And so that's something that's not known widely, and is something we often teach our patients. This is the normal dying process, and this is what it looks like. So that the concept of guilt associated with not feeding our loved ones, because such a cultural thing.
Right, because we want them to eat more and take more bites of this and do more of that, but if we understand the body really doesn't need that.
And so if we focus more of a pleasure, then it really allows families that freedom to let go of those feelings. So that's what's really important. At the end of life, depending on the disease, the symptoms are widely varied. Pain may or may not be a part of of it, breathlessness may be a part of it, agitation may be a part of it, swelling may be a part of it. And so every patient is very different with regards to their symptoms, and so therefore their medications are going to be very different.
So if there is agitation or swelling, things such as that, this is something that medically in that palliative hospice you would try to treat and to manage, that type of thing. Okay, and the aggressive turning, because sometimes when we are in the hospital setting, we think, well, they need to be turned every 2 hours, and they need to be this. Does that somewhat slow when we get to the end of life stages, because you just don't need to be turned quite as much? For some people, it may be more painful.
It's very true. Turning is important, especially for patients who are very thin, because bony prominences can, if they're rested upon too much, can actually cause wounds, and those can be much more painful. So gentle turning, when we see that the patient's been on their side too long or what have you, obviously with the risk of limiting the amount of pain that they're in. Those folks that are very good at the end of life, such as hospice nurses and aides, are very good at understanding how to gently turn someone. But turning is a very, very important part of terminal care, so that we don't develop wounds or any other pain-forming issues.
Let me ask this about sleep and rest then. How critical is the sleep and rest phenomena? Because sometimes when we're having visitors come in and to visit with people, especially when they're terminal, and sometimes people say, well, leave them alone, they're asleep. Should you wake them? I mean, does that really make a difference, or should you let them sleep? They really need that? I mean, how do we handle that?
Just talk to them. Ask the patient. Presence is very important. You know, oftentimes we think we need to have conversations and have an interaction, but just being present with someone who is terminally ill, physically in the room, emotionally present with them, is a key to that part of life. And it may not require a verbal communication, but maybe more than nonverbal, of just being there and bearing witness.
Okay, that's very interesting, because we do always feel like we need to talk. And in terms of sense and sense deprivation, hearing, sometimes people will say, and tell me if that's still true, that hearing is one of the last senses that we lose, so that we can hear even though we don't appear to be hearing. So talking or reading a book or doing things like that can still be helpful.
Yeah, it definitely can. You know, we're still better trying to really understand the dying process and what people go through, and pre-death phenomenon, post-death phenomenon. And one of the things that we do see is that hearing seems to be one of the last things to go. And we actually counsel families on that, keeping the environment quiet. But those gentle words, words of goodbye, words of forgiveness, and those things that people have to process before dying are very important to have. And so oftentimes recommend families say those things with sensitivity.
Thank you so much for joining me and helping us to understand.
Yeah.
Well, that's our show. For Health Alert, I'm Pam Butler. I'd love to hear your comments, questions, or suggestions for future shows. Please write me at Health Alert USA, P.O. Box 50913, Tulsa, Oklahoma 74150. Or if you're on the email trail, please email me at healthalertusa@gmail.com. And also visit me on YouTube at youtube.com/Health Alert USA. Take care, and remember, consider death as a part of life. Don't be afraid of it. Talk to your loved ones and kind of see what's going on, and just hang in there. Take care. Health Alert is brought to you by OU Physicians in Tulsa.